I just wanted to share with you just a little bit more about my own background. I had the very good fortune as an undergraduate of being a student in the History of Science department at Harvard, and that left that had a real profound impact on my own development. It is. Thank you. I went on to some graduate work in women's studies at Oxford, and at Oxford also got my master's of business administration. So I had quite a varied educational experience prior to starting down the path of medical training. I did my residency in neurology with specialization in child neurology, came to Columbia for my postdoctoral research fellowship, which was in the brain imaging lab. And then for a brief period of time, I was on the faculty here with joint appointments in the Department of Neurology and Psychiatry, which was very interesting. I really enjoy, as I think so many of you do, being sort of between departmental silos and crossing boundaries. And having a joint appointment between those two departments was quite a struggle. So what I experienced as I was going through my medical training, which in total was about 12 years, very deeply immersed in medical practice and biomedical research, was that the questions that I had been taught to ask as a student of the history of science and a student of women's studies were very prominent in my mind and created sort of a lens through which I viewed all the experiences that I was going through. That made for a really fascinating experience, but a very uncomfortable one, a lot of tension. And what was quite troubling to me was to see what seemed really like a complete absence of those questions and discussions in medical settings and among my medical colleagues. And I also saw how that absence led us to do harm and to be unaware of the harm that we were doing. So in my position now, I'm a neurologist and founder and chief medical officer of Cortica, which is a startup health services company aimed at providing comprehensive care to individuals with developmental disabilities. I've tried very much to have the work at our centers draw on the rich knowledge of the medical humanities. And as I was getting to see and share some notes on today's presentations with Peter and Jesse, I thought very carefully about what it is that I might contribute to this discussion. And I wanted to start with a case. So this is a case of a 19-year-old young man. Okay. This is a 19-year-old young man with autism spectrum disorder who I met at the age of 19. He had been diagnosed with autism at 2 years of age, was felt to be mild at the time, and so was given a diagnosis of pervasive developmental disorder not otherwise specified. This is no longer a diagnosis in the American Psychiatric Association's DSM, Diagnostic and Statistical Manual, but at the time it was given to those who were felt to have a mild presentation. And despite his mild presentation, he had very minimal progress in therapies over the years and periods of regression where rather than even advancing skill or maintaining skills, he had loss of skills. And in adolescence, he had a very high level of rigid, repetitive behaviors, rare, spontaneous language, and an escalation in agitation, aggression, self-injury, and destructive behaviors. And so when I met him, the parent's chief concern at our initial evaluation was grabbing and hitting his mother, throwing objects, destroying walls, furniture, and inappropriate public behavior, primarily masturbation in public. And so the conventional approach in the field of medicine, in neurology and psychiatry, to managing aggressive destructive behaviors in those with autism is multi-drug therapy, so use of antipsychotic medications, antidepressants, anti-anxiety medications, stimulants, mood stabilizers. And these have very high rates of adverse effects. And I'll note that their use, especially in combination, is off-label. So the way that they're used is not for the indication that the FDA has approved them, but their use is widespread. Residential institutional housing, and a strict behavioral approach. And I'll talk in a moment a little bit more about what that means, but part of that involves, for these individuals with extreme behaviors, confinement and restraint. And we know from long-term outcome studies that when you look at all of those with autism, even those with what we consider high functioning or high intellectual ability, or what previously was called Asperger's disorder, that even when you look at that full range, the independent living and full-time employment outcomes are very low, only 5 to 10% achieving those. And the remainder live at home with family or in institutional settings, and about 15% require hospital-level care. We know that the diagnoses of autism are rising, and a recent estimate of about 1.5% of U.S. children now being diagnosed with autism. And from the work of Dr. Behrman's group, we also know a lot about where that prevalence is coming from. And interestingly, about half of that is thought to likely be the result of an interaction of genetic susceptibilities with environmental risk factors. And there are several known environmental factors that confer risk for autism. And they include prenatal maternal infection, prematurity, short interpregnancy intervals, so short period of time between the previous pregnancy and the next pregnancy confers risk to the second pregnancy, exposure to air pollutants, and to endocrine disrupting chemicals such as organophosphates, which are found in pesticides, and phthalates, which are found in plastics. This is a study that was just published in May of this year, of 2017, out of Stanford, where they showed that the demand for autism treatment services is 18 times in excess of supply. And this is a study that estimated the lifetime per capita societal cost of autism at $3.2 million, which is primarily through the cost of adult care and lost productivity. And so what a child or family with autism faces now in terms of autism treatment is a highly fragmented state. And my view is that this is very much the consequence of the boundaries and the artificial distinctions that have come about in terms of the way that we conduct research. So that this is the result of how we've gone about pursuing scholarship rather than a reflection of the human organism, the child, the family, whom we're trying to serve. And so the family immediately encounters the medical establishment, medical services. They'll be directed towards services in applied behavior analysis, which I'll talk more about in a moment, speech language therapy, physical therapy, occupational therapy, music therapy, neuromodulation therapies, psychiatric and psychological services, nutrition services, relationship-based therapies, and a range of school services. And as part of encountering those things as sort of services that we have, as a field, deemed are useful or appropriate for that child, they encounter language. So frameworks, models, explanations, and language that is all sort of converges on the child. And these are just some examples, but it gets very complex. In fact, the professionals that occupy each of these different departments very rarely speak the language of another department. So professionals have a hard time navigating the variety, and so families have an even more difficult time. And so I think what we observe in clinical practice is the toll that takes on the child and the family. So how did we get here? The first description of autism in the medical research literature was in 1943 in a case series written by Leo Connor, who was the chief of the first child psychiatry department in the U.S., which was at Johns Hopkins University. And his case series was called Autistic Disturbances of Affective Contact. And what was really interesting about his case series was how detailed and how sort of close to the experience and the observations of the families his account was. And his only effort at sort of suggesting causation was to say that he observed in some of the parents of these children some qualities that the children had as well, so some tendency toward, for example, rigid behaviors. What then sprang up in the decades to follow were a lot of other theories about the underlying causes of autism. This was one that was published in the mid-1960s by Bernard Rimland, called Infantile Autism, the Syndrome and Its Implications for a Neural Theory of Behavior, where he posited a neurobiological basis for autism. A few years later, this book was published by the psychoanalyst and academic Bruno Bettelheim, The Empty Fortress, Infantile Autism and the Birth of the Self, in which he posited a very different theory to explain the behaviors that were being observed. And his theory was that they were caused by refrigerator mothers so by mothers who were emotionally unavailable and frigid towards their children. This is a documentary produced recently by PBS, where women who had been told by their medical providers that they were the cause of their child's autism had the opportunity to speak out and share what that experience was like for them. Now, also in the 1960s, some research was being done at UCLA, and these are images of the psychologist O.I. Lovaas, who spearheaded the development of a technique that remains the dominant therapeutic approach used for autism today, called applied behavior analysis. And this is the title from a Life magazine article discussing his work. Applied behavior analysis, ABA, is a therapeutic modality based in behaviorism, which is an approach to psychology concerned with observable behaviors. ABA is characterized by the collection of data to quantify behavior, and then steps are taken to reduce unwanted behaviors and to increase desirable behaviors. And the field has a term, private events, which they use to describe processes that cannot be observed. Neural processes, which they deem to be outside of the scope of ABA. So as I was, as a neurologist, most neurologists, as part of our training, don't have a lot of exposure to ABA. But as I began to explore and learn more about this very important so-called evidence-based therapeutic modality for the treatment of autism, it seemed very curious to me that one of the fundamental sort of foundational elements of neuroscience, what I would consider neuroscience and neurology 101, that the brain and the nervous system is designed for sensory perception, neural processing in a very general sense, and then movement, behavior, response to that. That the dominant approach to the treatment of this very important childhood brain disorder was one that had no space for the consideration of these very important neural processes. And so this remains the case. And I'll just give you an example of how I feel that cognitive neuroscience can now inform and help this field to develop. So this is a research paper that we published in 2013. I published with some colleagues of mine here at Columbia University, where we did a clinical trial, a pilot study, of a 9-month reading, writing, and typing intervention in a group of children with autism ages 5 to 13 who were nonverbal or minimally verbal. And we were able to show that of those who received the intervention, close to half were able to read and write with comprehension in the absence of spoken language. So a lot of research has been done now in autism to show that there's an enhanced visual processing capability, enhanced visual memory, that the phenomenon of hyperlexia, which is the precocious ability to read before the 2 years of age, is highly, highly associated with autism. And that if we were to consider more than simply the behaviors of these individuals and think about the underlying neural processes, we'd be able to offer more appropriate therapies, and specifically therapies that leverage the enhanced visual processing capability and don't rely so heavily on auditory processing, which we know is more difficult for those with autism. And so one of the things that we do in the clinical care we provide is that we really value and privilege language and techniques and approaches that are comfortable and familiar for the families and the children that we work with. And so one of the ways that we try to make concepts understandable, like visual processing, visual memory, auditory processing, auditory memory, is that we try to provide them with examples that they can relate to. So this is one of my favorite examples. It comes from carpool karaoke, and it's one of the ways that we use to help families to understand what it might mean to have one's auditory processing capabilities exceeded. So that's a very difficult auditory processing task, and what helps is a visual support. So if you were asked to do that task, I think most of us would have some trouble, but given a visual support and a little bit of time, processing time, we might be able to do it. So I want to share with you, one of the things that's been a bit of an obsession for me over the years has been what could be done in the clinic, in the treatment space, sort of on the front lines, that would draw from the medical humanities. And so one of the things that we've done, so we have 2 centers in California, serve about 800 families, and we have a clinical care model that targets all of these 6 domains, which I've listed here: neurophysiology, biochemistry, sensory motor integration, communication, cognition and behavior, family and home. And so one of the things that we're saying is that there can be a therapeutic place that, in a sense, attempts to break down some of these boundaries. That we bring together an interdisciplinary team of professionals trained in very, very different ways with different models, using language from their own field, their own disciplines, but we can come together, that we privilege terms that are understood across disciplines and by family members, and that we come to a shared construction of the problem and shared goals that's co-created by the child, the family, and the professional team. So this is sort of the experiment that I've embarked on, and has been very gratifying. And then I'll just close to say a little bit more about one of these domains, family and home, which is that we've put a lot of thought into how we've designed what we call our family program. And so I think that's okay. So our family program is led by a group of social workers and marriage family therapists. And in my medical training, it always seemed unusual to me that families coming to us who we knew were very often in a state of high stress and crisis weren't provided this type of support. So one of the things that we do immediately as part of our neurological evaluation is that we pair each family with a social worker or marriage family therapist who serves as an educator, a counselor, a care coordinator, and an advocate. And the approach that we've trained this team in, under the supervision of one of the faculty members, Ron Estes at San Diego State University, is an approach to therapy that's been termed narrative therapy. And it represents an alternative to conventional psychiatric disease-based model of care, in which the patient has a disorder or disease that's been defined by the practitioner, and the practitioner applies a treatment based on the disorder. So in the disease-based model, the patient has a pathology, and the patient and the problem are seen as one. And as an alternative, we adopt an approach to create a therapeutic environment where the context and conditions for learning are present, exploring alternative explanations and understandings of the problem and actions that could be taken, and employing questions that help individuals, family members, and those with autism themselves more richly describe what they value, what they can do, and what they do know. And as an organizational culture, the practices that we adopt with our clients are also the practices that we adopt with our colleagues. And these practices inform how we understand and approach problems that arise in our organization, of which there are many. And as an example, we speak and write of others as if they were present, including how we document inpatient charts. And we have an understanding of institutional models, discourses, and how these act upon us and our work, and work together to find solutions. So thank you.